Dear Chairman, ladies and gentlemen, this is my pleasure to present you this case report, which is a complication of an unsatisfactory coronary angiogram performed in a gentleman 1 year after TAVI. So basically, this 70-year-old gentleman present at the emergency unit of Georges Pompidou with an IAWACH class 3, and the medical history is a heavy risk factor with hypertension, diabetes type 2, overweight, heavy smoker, severe coronary artery disease since 1995, in 3 stents in the coronary, right coronary artery and 2 stents in the LAD. And in September 2021, he got a positive thallium with inferior septal, apical, and anterobasal ischemia. He has got atrial fibrillation, has bled 5, and he got an AF occluder in 2020. And he got also a terminal renal heart failure with a creatinine clearance of 18 and severe aortic stenosis. Got a TAVI in 2020 plus post-TAVI a micro PM for bradyarrhythmia. So the first hospitalization, global heart failure, he got a suboptimal response to heavy dose of furosemide IV. Ejection fraction went from 55 after TAVR to 45, normal core valve at echo, and coronary angiogram limited by grade 4 renal failure and by the core valve, so it was a suboptimal. As you can see here, there was a TIMI-3 on the LAD, circumflex, and also on the radial, but the quality of the angio is really suboptimal. The patient was released with a slightly better clinical function, and then he was re-hospitalized 1 week after in global heart failure, chest pain, and troponin elevation. The ejection fraction dropped from 45 the week before to 40%. And then we consider that it was a mistake and he should go get a satisfactory evaluation of the coronary arteries with no more concern of the terminal renal failure. This is a presentation showing, in fact, a favorable versus unfavorable situation for coronary access. And we know that there is a risk plane and valve-to-valve artery distance to take in account. So the success rate for coronary angiogram dropping to 69% successful PCI, and with the Edward valve, 94% in both cases. So what do we propose? In fact, in order not to absolutely directly introduce the guiding catheter in the ostium of the coronary artery, I did some injection in order to be in front of the ostium, and then with the guiding wire, I penetrated in the coronary artery, and then the second, after having done that, I inserted a guide liner over the wire into the RCA. And then I was able, without having a selective position of the guiding catheter, to be selective in the coronary artery. And as you can see, then we can have a nice angio showing 3 different stenosis, native stenosis, incendiary stenosis inside the coronary artery. As you can see, based on the guide liner, we were able to introduce a balloon and stent to fix the correct coronary artery. And in this view, we can see the final result with the patent artery with a TIMI flow, but without any more stenosis. Let's go to the left coronary artery with the same situation with Judkins left 4. We were able to evaluate whether we were in front of even at the distance, not in the ostium, but just in front of the ostium, catheterization with a guiding wire, BMW, and then inserting the guide liner on the wire, and then be able to perform a nice selective angiogram in order to verify the stenosis, and then fix the stenosis with a stent, and then controlling the story. So now we are fixed. The evolution was very spectacular. Stop dobutamine in 24 hours, reduction of furosemide from 1 gram to 160 milligrams in 72 hours, clinical improvement of right and left heart failure in 48 hours, improvement early at day 3 of ejection fraction measure from 40 to 51%, and back home 4 days after stenting with NIHA2, and creatine clearance even increased. So the outcome of unstable angina, ST9 and ST plus post-TAVI, you can see that ST minus or ST plus MI have a very, very bad outcome. So this slide from Mentiana showed clearly that the survival is based on an invasive approach instead of the conservative approach in case of an acute coronary syndrome. This slide shows nicely the MI type by time of presentation, and basically in 90% of the cases this is a ST minus acute MI, and ST plus is 10 to 15%, but it still occurs after 6 months. So in this slide, Mentia's meta-analysis shows that in fact the predictor of invasive compared to conservative is clearly the STEMI versus unstable angina, but you should go even if it is unstable angina and not STEMI, because definitely the prognosis is in favor of intervention. Presentation of cardiogenic shock. Don't wait for a cardiogenic shock to absolutely go inside your coronary arteries. And then a prior coronary artery disease. So if you compare the in-hospital mortality, 30 days, and 1 year mortality, it is simply the double, 4.8 to 8.4 in hospital, 8.8 to 16.9 invasive versus conservative, and at 1 year, 29 versus 44% of mortality with a conservative strategy. So there is definitely increase of delayed coronary occlusion with the self-expandable compared to the balloon expandable, and the valve-in-valve is in fact threefold higher, is a very high risk. With this work of Jabour, we can see that there are majority of early obstruction, but you have also delayed obstruction from day 30 to day 900, in which you still have cases of obstruction. So in this paper of Oshial, you can evaluate by CT identified feature of unfavorable coronary access after TAVR, whether the ostia are below or in front of this. So with this evaluation, Abdelghani, again with the CT, shows clearly that the distance between the ostium and the valve is critical, should be bigger than 2 millimeters, and also the distance from the annulus to the ostium is also very important. So practically, all the authors really try to find solution to introduce specifically the guiding catheter through the TAVR, but in fact, with the method I proposed, maybe we can be circumvent the difficulty with the wire and then with the guideliner or any equivalent system. So again, the message is clearly that coronary catheterization may be challenging after TAVR. That outcome is definitely better if acute coronary syndrome treated by PCI, and coronary access may be facilitated by wiring the coronary artery, access to the coronary artery by the guideliner, easy for performing selective angiogram and stenting. Thank you.